Hello all. I would like to take a few moments to make sure we are all on this, looking for the same information here. This is a content review for Nursing 421, and our topic for today is about cardiac. So we're going to review the cardiac content that you need to be able to understand for your first exam in Nursing 421. My name is Professor Land, and I am one of the theory instructors. So welcome. So first, we're going to talk about the indications for hemodynamic monitoring. Please know that anytime we need to assess cardiac function and be able to evaluate any kind of therapy effectiveness, we're going to need to know what hemodynamic monitoring and assess that for all patients. We actually need some more detailed or most accurate information when we have patients who are in cardiogenic shock, severe heart failure, sepsis, sepsis shock, multi-organ system dysfunction, acute respiratory distress syndrome, and open heart surgery patients. On the screen, you will see two links for you to go and look at some information to help you have a better understanding of pressure monitoring. Edwards Life Sciences is an organization that creates supplies for hemodynamic monitoring and some other items that are used in complex and critical care. The first white link is about arterial lines and transducers and leveling, okay? The second one is about an insertion of a PA catheter. And if you go look at those, it will allow you to have a better understanding of the rest of this content, okay? So we need to make sure that when we are using a transducer for either the artery or the pulmonary arteries, then we need to make sure that we are level with the heart. And to do that, there is a landmark on the body. To find that, you are to count down to the fourth intercostal space, then move around to the mid-axillary point, and that point is where the right atrium will be sitting, and that is where accurate readings will be obtained. On the B section here, you see a 0, a 30, and a 60-degree photo. Research has shown that if you re-level at each level that the patient's head of bed is at, while it is there, you will get accurate readings. If you readjust the head, you need to re-level. We used to think we had to leave them at 0, and every time we put them down flat to get this reading, can you imagine how uncomfortable it would be if you had your chest or your abdomen cut open and they were stretching you? So very uncomfortable. Okay, so now we're going to go and talk specifically about arterial pressure monitoring. This allows us the opportunity to continuously monitor blood pressure. Okay, this gives us a constant readout. Every time your heart beats, you will get another measurement of your blood pressure every time. So continuous gives us the ability to see it real time. This also helps us in a number of ways. If I try to get a blood pressure cuff reading on someone with an actual peripheral cuff, every time I blow it up and repeat the use, then I'm going to cause bruising and some falsely elevated readings of the blood pressure. So this actually helps us prevent further injury and actually assists us in making sure we are offering treatment which is based on appropriate and accurate readings. It also gives us an opportunity for access to blood for running labs and things like that without having to multiply stick the patient, which are very uncomfortable. We use, again, like I said, the blood pressure for guiding our therapy with many of our vasoactive medications and our nitrates. So let's look at some nursing interventions for the arterial lines. The first thing I want to say is that you need to ensure that the insertion site is visible at all times. And you will see that it is always covered in a clear dressing so that it could be visualized. The insertion site can be visualized. To add to that, please ensure that the arm is above the linens, because if there's a leak of blood, it's an artery, and you will lose a lot of blood prior to it soaking through bed linens. And having it above the linens, you can see that happen sooner and not have any concerns about the amount of blood loss that might have occurred if you didn't catch it. You also need to ensure that your monitors for the arterial line are on and audible. I can tell you for ART lines and for PA catheter lines and EKGs, it is actually not a good thing to ever turn off your alarms. They are to be used to be vigilant in the care of your patient and to let you know when the parameters have changed so that you may want to adjust your alarms and monitor the patient's current trend. Again, with that information, you may have to adjust those parameters based on your facility's protocol. And I will tell you the standard is that it's 10 to 20 millimeters of mercury from the patient's trended blood pressure. So if it's 120 systolic, then you're probably going to say, okay, I need to have either 130 or 140 as my upper limit, and I need to have 100 or 110 as my lower limit for my systolic blood pressure. Significantly, you need to be aware that you are not to ever infuse any kind of IV solutions via the arterial line. You have to remember that when you are inserting medications or IVs or whatever through the venous system through an IV line, it is actually flowing back to the heart so that it can be mixed in the right atrium and then processed and then sent out to the body. If you use the arterial line and infuse that, you must know that the arterial flow is going in the opposite direction, and so if, let's say it's in the radial artery, whatever you infuse there will actually go to the hand and more than likely stay there, not go where we might need it to go. And then, of course, depending on what the medication is, we have to be very concerned about damage to the tissue, to the actual hand itself, and the loss of motor control. So this is what a, quote, textbook arterial line waveform is to look like. You see the top of the arching is where the systolic blood pressure reading is, and then the bottom where it says end diastole, that's where your lower reading is at. There is actually a diacritic notch there. So a good waveform will have nice rounded waves. They'll go up, a nice round top, they'll come down, and you will visibly be able to see this diacritic notch. And it will be a nice round. If you remember from med-surg, the diacritic notch is where the valves in the heart close. And that is where you will see that actually happen on the arterial waveform, because it does cause a little bit of an adjustment in pressure when those valves close. So anytime we're talking about an invasive line of any kind, we must think about the complications. So for an art line, again, blood loss, right? One way to make sure that that is prevented, you want to make sure that all of your connections, so where that line connects to the catheter at the insertion site, where it connects along the IV line to the pressurized infusion fluids, all have to be very tight and secure. Otherwise, it will allow blood to back up because there won't be enough pressure to keep it inside the patient's body. It will come back up through the line of least resistance, which is back out to the outside in atmospheric pressure. Also, you will want to immobilize the extremity because, again, being that this is in an artery, anytime you have any kind of device that is inserted through the skin, you actually stretch the opening. When you move your wrist forward and back or around and around or side to side, you are actually stretching the opening. If that happens with an arterial line, you can have arterial blood loss from around the insertion site because it was widened due to activity. So we actually have special devices to immobilize the wrist. And again, you want to be able to see that insertion site, so keep it above any linens. So anytime we invade the body, we have to be concerned with infection. This, again, should be maintained as an entirely closed system and not opened in any way to the outside. Anytime you are changing the dressing on the arterial line or changing the tubing or anything, you must ensure you're observing strict sterile technique, because remember, and this is directly into the arterial line. So if I have an infection in the artery, that means it is a sepsis situation, and you know, it's way greater than 50% mortality rates for those who get sepsis, and then I think it's like 75% to 85% who have septic shock. So it is something we need to be very aware of and monitor for vigilantly. Before an arterial line is inserted into a radial artery, an Allen test needs to be done. So I'm hoping you recall that from your med-surg days. Okay, so you're going to clamp your hand around or be able to close off the radial and the ulnar nerve, the radial and ulnar arteries at the same time. Once the hand starts getting tingly, you should see the color of the skin become dusky. At that point, the ulnar artery is released and the radial artery is maintained pressed closed. If the duskiness and the numbness kind of fades, then we have adequate ulnar collateral circulation that the radial will handle an insertion of a device into it. If it does not improve, it stays dusky, it stays numb, then that compromised circulation means we cannot use that area. We really don't want to lose somebody's hand while we're trying to help them. So this needs to be monitored for. That impaired circulation, once you have an art line in, you have to continue to monitor the color, the sensation, temperature, and the movement. So CMS is color, movement, and sensation, and then of course the temperature. We have to monitor that continuously because if it becomes compromised later on, we want to make sure that we remove the device and prevent any permanent harm. So this is a memory slide that I actually purchased the right to use these in my classes and stuff. One term you need to remember from med-surg is preload. and the other term is afterload. Please remember that the preload is the actual amount of pressure that is in the ventricle when it is stretched and completely filled at the end of diastole. This is just prior to the contractility taking place of the ventricle. Okay? Now, preload will be increased if I have too much volume. And I can have too much volume because I actually have a leaky valve. And it means that the fluid gets stuck in the ventricle and I can't get forward movement because the valve doesn't close well to help push it out. Okay? Another way that that can happen is heart failure. You know, my left ventricle may not be functioning optimally, and I have a weak contractility, and I am not able to get forward flow as well. Afterload is the amount of resistance that the left ventricle must overcome to circulate the blood. So some ways you can look at it is how much pressure is needed to open the aortic valve and allow the blood to flow through to the rest of the body. And so that's the afterload. I can tell you that afterload is increased when you have hypertension or some other vasoconstriction, which actually increases SVR. And we're going to talk about SVR in just a few moments. If you have increase in afterload, you are going to cause the heart to work harder. So we increase the cardiac workload. So it's not always the best choice to go. And there'll be some times that you will not monitor the pre and afterload, and that will make a determination on whether you need to give fluids or you need to give diuretics or maybe give some kind of a contractility medication to help improve the ability to contract. I hope you remember that heart rate times stroke volume equals cardiac output from your med surge. It's easy for us to get heart rate, but for stroke volume, we have no way to do stroke volume without doing a Doppler ultrasound or invasion procedures to actually look at the stroke volume. And a PA catheter will enable us to do that. And once I can do that and know the stroke volume, I can calculate a patient's cardiac output. Okay? Moving forward, we're going to talk about central venous lines and central venous pressure monitoring. Okay, so I'm talking about a CVP, central venous pressure. Please know that this is where a large bore IV is threaded through either the jugular or the subclavian line, circulatory system. And the opening of the catheter is at the top of the right atrium, but not in the right atrium. Normal parameters here are 2 to 8, and that is a reflection of the right ventricular end diastolic pressure, which gives you an idea of what your intravascular blood volume is. So it gives you a reflection of how much fluid you have in your body. Complications are the same for this because it's the same as arterial line. We must be very careful about infection. We have to assess the site. Anytime we are manipulating the catheter or changing the dressing, we must make sure that we are doing extremely strict sterile technique. The catheter lumen actually narrows down as it comes to the end point, and we have to be aware of the fact that small blood clots can form on the end of that. Anytime you are monitoring your waveform and you see that it gets smaller and squatty, or you have difficulty flushing the line, or you cannot get blood return, then you probably have to consider that there's a thrombus somewhere. One of the complications you need to remember is that we use the subclavian for insertion of catheters that are going to be central venous catheters. Well, we must remember with our anatomy and physiology that lying right behind that subclavian vessel is the upper lobe of your lung. It is extremely easy for the subclavian artery or venous system actually to be punctured all the way through, and then in result, the upper lobe to be punctured, resulting in a pneumothorax. If you do not confirm that your line is in the proper placement, if you did, collapse the lung, you will then be infusing fluid into either the thoracic cavity or directly into the lung itself. There's also the opportunity for a catheter to turn on itself and then be fed upwards into the carotids, and if you infuse anything without confirming placement, then you are actually bathing the brain directly in whatever you are infusing. And I will tell you, it doesn't really like a lot of things directly on the brain, and seizures can be one of the smallest issues that can arise. Air embolism is very easy to happen because in the artery we have blood forcing its way out, so air cannot get sucked into the arterial system. But when we're talking about the venous system, remember the blood pressure is coming out of the left ventricle and going out to the systemic vasculature. Well, then we have veins that have all these valves that help push the blood back up the body, fighting gravity, and so that it can empty into the right atrium. Well, if a valve does not work, or we have the ability to allow the patient to take a deep breath when one of these central venous lines are being removed, we actually allow air to enter the venous system, creating the potential, or generally, an air embolism. So again, we need to ensure that all of our connections are tight to prevent that issue. Here's another memory slide that I'm hoping is going to help you have a better understanding of the pulmonary artery catheter and where each thing is. So this is your subclavian vessel. This is your superior vena cava, and this is your inferior vena cava. From the placement of this catheter, it came from the right groin up through the inferior vena cava and entered into the right atrium. Once it's entered into the right atrium, if you'll see this little balloon on the end, that balloon is inflated with this syringe. And the provider is the person who is inserting this catheter. They are in control of inflating the syringe and the balloon, okay? The balloon is inflated so that the blood flow will actually carry the catheter through the right atrium, through the right ventricle, up into the pulmonary artery, okay? Once it gets into the pulmonary artery, it actually, remember, you have to remember that we go from arteries to arterioles to capillaries, and then we go to venules and venous. So things continuously narrow down and get smaller and smaller. So eventually the balloon will not be able to move forward because it will be in too tight of a quarters. That is called a wedge. It's wedged into place. And when it's a pulmonary capillary wedged pressure, it is also a pulmonary artery occlusive pressure, because if it's wedged in there, it is occluding any blood flow to move forward. Another term that it is called is just a wedge, okay? Now please remember that you will have increased heart chamber pressures when you have heart failure. So the blood gets trapped in here, making the pressures go up. If you have dehydration, hypovolemia, your pressures inside the heart will be low because there's not enough volume to circulate. So I hope that helps you. The pulmonary artery catheter has multiple lumens. There's the balloon. There's a temperature lumen. There's also a distal, a proximal, and a pulmonary artery. And we're going to see some of that. And there are some PA catheters that actually have even more than these. So this is what a pulmonary artery catheter looks like. It must be inserted through an introducer, which is a very large bore device that is inserted into the vessel, and it has to be large enough that this yellow line, this yellow catheter, can be inserted within the lumen of that device. Okay, so it's actually called an introducer, and then the PA catheter is fed through that. Okay, there's a lock here and a lock here, and then all of this plastic is called a sterile sheath. That enables the physician to advance or withdraw this catheter without being concerned of contamination of this particular area of the catheter. Because once it's contaminated, it can never be advanced. Okay? This introducer actually has 2 extra IV infusion ports. Okay? Now, we have the red balloon port. This is where we take that syringe and we inflate the balloon. Okay? The balloon is actually down here. It got cut off. This one is the one that gives you your PA readings. And just like your blood pressure for, peripheral blood pressure, there's a systolic and a diastolic. Well, when you're looking at a pulmonary artery, you're looking at a pulmonary artery pressure, and it has a systolic and a diastolic. Those are reflected from this port, and it's standardized that be a yellow waveform on your monitor. Okay. This white port is actually another infusion port. This larger cardiac output port is this piece right here, connects to a cable that then connects to a continuous cardiac output monitor that gives you cardiac output readings, it gives you cardiac index readings, helps you calculate SVRs and PVRs, and it also can allow you to have SVO2 readings, which are saturated venous oxygenation readings. And that's like how much oxygen is still left in the blood after the circulation has been returned back to the right atrium. That's sometimes referred to as the oxygen reserve of that patient. The blue one, the blue port here, is your CVP, which is we discussed as your central venous pressure. And as it might seem logical, it's blue, and standardized protocols have said that will be a blue wave on the monitor. Okay? So let's just look at where this would take effect within the patient's system. Okay? So the CVP is a blue line. That's number 1. And it will actually stop right at the right atrium. Okay? The balloon port comes all the way down, and it blows up this little black balloon. And what happens is, as it's usually like right here, bouncing with each heartbeat. When the balloon is inflated, the blood flow will capture that balloon and carry it forward until it can't move forward any further. It gets wedged into place. It wedges into place, and it occludes any forward flow further down. Okay? As the balloon is decreased or dropped, then the catheter no longer has that flow rushing by, and it returns back to around this area, and it bounces with each heartbeat. Okay? There is a thermistor down here. It's actually coiled copper, and it goes with this port here, the cardiac output port, and it gives you the opportunity to have continuous readouts of the temperature, just as much as getting continuous readouts of cardiac output. Okay, just to give you a little bit of an idea of what it might look like and exactly how things are working. So when you're dealing with pulmonary artery catheters, there are many things that you do to help as a nurse. Okay, one of those is to help the provider do the insertion. There must be a consent form signed, and then it must be a trained and competency verified provider who actually does the insertion. The nurse, your job is to help make sure that the connections are all tight, everything's set up correctly, you do the timeout after the consent is signed, and then during the actual insertion, it is your responsibility to monitor the waveforms and monitor for any dysrhythmias. One of the biggest dysrhythmias that you will see during insertion is VTAC, because it's irritable to the left ventricular wall if the balloon gets pushed down into the base of the ventricle rather than floating down around and then back up into the PA. Okay? If that happens, you will just say VTAC, and the doctor will pull back, or the provider will pull back, and then he will give it another opportunity to try to float up into the PA. Now, when we inflate the balloon, we have a purposeful wedging, okay? We can only do that for just a few seconds, and then the balloon must be let down. If the catheter moves forward enough that it started wedging without having the balloon inflated, then that means your catheter has migrated forward, and you can't leave it there or we will have a pulmonary infarct, okay? So when that happens, there's usually a protocol that nurses can pull the catheter back, typically to the central venous in the right atrial area. And then, of course, in the sterile sheath, when the physician comes back in to correct this, he has the ability then to feed this back into where he would like for it to be, because it's still sterile. Please remember that we must maintain strict sterile dressing changes, and that the placement must be confirmed by chest x-ray before you access and utilize the device. Okay? Well, now let's look at data interpretation. So the right atrial pressure correlates with the CVP, all right? The right atrial pressure is a little bit more accurate, 2 to 6, because it's actually taking the measurement of the pressure within the right atrium. The CVP is measuring the pressure from just outside of the right atrium in the vena cava, okay, just at the top of the right atrium. So the CVP can be 2 to 8. Your right atrium will be 2 to 6, which is a little bit more accurate. We use them interchangeable, and on any exams that you have with school or even the NCLEX, nobody will ask you about 6, 7, or 8. If you have anything less than 2, it is a dehydration. You can have potentially negative numbers. I've seen a negative 10, and the patient was extremely dehydrated. You can also see something that is significantly elevated. It would, you know, the lowest you're probably going to see on an exam would be a 10, 11, 12. And so those are obviously elevated pressures. And that's typically when you have too much volume. Okay, that's fluid overload. The right ventricular pressure, we're going to move forward and discuss that. Please remember the right atrial pressure and the CVP reflect the right ventricular end diastolic pressure. So what the right ventricle has within the chamber, pressure-wise and volume-wise, just prior to contraction, okay? The next one is the pulmonary artery, and again, we're measuring a blood pressure inside the pulmonary bed. So we will have a systolic and a diastolic reading. The systolic reading parameters are 20 to 30. Well, yeah, I mean, the pulmonary bed should have an entirely small amount of resistance or tightening compared to a cuff pressure or a systemic pressure. So 20 to 30 versus 120 to 130, okay? Your diastolic pressure actually reflects the left ventricular end diastolic pressure, and the normal parameters are 8 to 15. Now, remember I said the CVP is the broad number, 2 to 8, and the right atrium reflects the right ventricular end pressure, and it is more accurate, right? And it's 2 to 6. We have the same possibility with the pulmonary artery wedge pressure, okay? It is more correct or more accurate at 8 to 12. However, there are some deadly complications when you are wedging, and the majority of facilities and hospitals no longer request or require that the catheter be wedged. Once it's been placed, they would prefer that you use the diastolic reading. So we're going to go with 8 to 15 being your low parameters, okay? So if ventricular dysrhythmias are possible with the insertion, they are even possible while it just sits there, okay? We must be concerned about that pulmonary artery being ruptured or even be poked through while we're putting the insertion in and the balloon is inflated, which is also why they prefer that you not do the wedge and just use the PA diastolic rating to get that left ventricular end diastolic pressure. Now, if we leave it wedged or it wedges accidentally, there's no blood flow beyond where it's wedged. That means we have a pulmonary infarct. So, well then why would we use a PA catheter? Well, there's some information that we need when your patient is extremely ill that you can't get in detail without having a catheter to help you get those pressure readings. From med-surg, your terminology that you need to be refamiliarizing yourself with is preload, afterload, cardiac output, cardiac index, SVR, which is systemic vascular resistance, and PVR, which is pulmonary vascular resistance. Okay? Cardiac output, that is the amount of blood that is ejected from the heart, the left ventricle, per minute. Stroke volume is the actual measurement of milliliters of blood that is ejected from the left ventricle with each contraction. And remember, heart rate times stroke volume gives us a cardiac output. But we can't do stroke volume without some kind of device to help us measure that. All right? Normal cardiac parameters are 4 to 8 liters per minute at rest. At rest. Cardiac index is where we actually take the cardiac output and we utilize the patient's height and weight and get the body surface area. We can actually then individualize the cardiac output to that particular patient's body size. That is called a cardiac index. Okay? So an output is 4 to 8 as the normal parameters. An index is 2.5 to 4. Anything less than 2.5 is abnormal. In open heart surgery patients, anything less than 2.0 must be taken care of because the patient was already compromised and cannot afford to have anything less than 2.0 minimum. So talking about stroke volume, preload is the amount of actual stretch on the myocardial fibers when it's completely full at end diastole. So as a balloon fills up, it stretches. Okay? Same with the ventricular chamber. There is elasticity to muscle, right? It contracts and relaxes. Well, as it relaxes, it allows for stretch. Do you remember Stirling's law from med-surg? A little bit extra stretch makes a little bit extra tight rebound, right? So preload utilizes Stirling's law. A little bit extra stretch, okay? It will help a faster rebound and overcome any afterload issues, okay? So preload is the amount of stretch with a full chamber. Afterload is the resistance that the ventricle must overcome in order to open the aortic valve and actually push against the systemic resistance and get the blood to flow out to the aorta, okay? Now, contractility is the actual ability of the left ventricle muscle to contract strongly or weakly. Contractility is able to increase contractility and overcome afterload that might be too high, okay? Or if afterload is not very high at all, then the heart goes, okay, I don't have to work so hard. And we'll talk a little bit more about how that gets changed or altered in just a moment. So looking at SVR and PVR a little bit more, the systemic vascular resistance reflects the left ventricular afterload. Remember, that's what has to be overcome. Pulmonary vascular resistance actually reflects the right ventricular afterload. Many of the medications that we are going to be administering to complex care patients are cardiothoracic or cardiotonic medications that will actually have direct effect on preload, afterload, SVR, PVR, and cardiac output. So we cannot treat these things if we do not know what normal is and what effect these drugs will have on them. There are actually 2 YouTube videos here. They share with you some information on how does the PA catheter get where it needs to go, how does it get the information that it needs, and what do you do with that information. The second one is another educator's PowerPoint presentation regarding hemodynamics. She's a clinical nurse specialist at a facility, and she does a really good job. So I would like you to have the opportunity to find someone else's information to see if maybe you can get a better grasp or a better understanding if you're not able to get this one. So now that we have all this information, when do we use it? Well, if somebody has an acute myocardial infarction, we need to be able to treat that infarction appropriately, and we need to assess that person's pain and myocardial infarction severity. So you're going to look at the PQRST, how severe, sometimes crushing and squeezing pressure. It may radiate. Sometimes it's unrelieved with nitrates, making it unstable chest pain, okay? Patients usually present with pale and diaphoretic skin. They are short of breath and even tachypnic. Many times the blood pressure is low enough that when they stand up, they pass out. That's called a syncopal episode. With the proximity of the vagus nerve with the cardiac and the GI system being right there together, nausea and vomiting is typical with acute MIs. And of course, with the musculature of the heart not getting enough oxygen, it will have dysrhythmias. It will create dysrhythmias because that's the way the heart cries out when it is not getting what it needs for survival. You already know about the diagnosis of an acute MI, so please remember you still are going to need the 12-lead EKG. Look for ST elevation with or without Q waves. Look at your cardiac enzymes and your serum troponins. But please keep in mind that men and women present differently and that women have atypical symptomatology of acute MI. And many times it is a back or a shoulder pain. Your goal is to maintain standards of practice. And out in the practicing world, they call them core measures. Well, you are to maintain effective cardiac output for that patient. You need to then treat the pain. Why do I say maintain cardiac output? Well, if I don't have heart output, how long will I have to treat that pain? Not long. I need to keep them alive, and then I can treat the pain. You're then going to assess for any kind of complications. You actually want to then increase the patient's activity gradually so that they increase their tolerance gradually. Of course, we need to relieve anxiety and concerns, and we need to have ongoing and discharge teaching starting immediately. Medical management, of course, we're looking at MONA. MONA, you remember that from med-surg. Aspirin is the last letter for that MONA treatment. We also use beta blockers such as metoprolol, nitrates like nitroglycerin, sublingual, or even an IV drip. We have ACE inhibitors, calcium channel blockers, and then also antidysrhythmics. Okay? The calcium channel blockers are not the drug of choice for acute MI, but they can be used when patients have also hypertension issues. So let's say we have an unstable angina patient, or we have such a severe MI that a lot of tissue is damaged, or somebody has gone to cath lab and they have tried to stent it open, stent the issue open, and it has failed. That is an indication for a coronary artery bypass graft. That has a slang terminology of a cabbage. And we have to monitor extremely closely all of the hemodynamic parameters when patients have open heart surgery, because we are actually manipulating the chambers and the muscle and the valves and the blood vessels. Okay? Another thing you need to recall from your med-surg days is permanent pacemakers. You need to know about programming the rate, the voltage, which we call the MA, the sensitivity, meaning how sensitive is it? Are we going to pick up a lot of artifact, or are we damping it down so that we're not picking up even regular beats? Okay? The stimulus duration and the refractory period are used for permanent pacemakers, and as a general nursing practitioner, it is not mandatory that you understand that part. What you do need to understand is the pacemaker code chart, the first, second, and third letters. You need to understand what they mean, okay? Permanent pacemakers can be adjusted from the outside of the skin using a specific magnet. Some people have been able to see in some of the med-surg units in the med room or in the ER a large round blue magnet that has a hole in the middle. That magnet is utilized over a permanent pacemaker so that we can adjust settings, and that would not be done by a nurse. That is only done by a provider who has been trained and certified. Okay? So let's say we've had an acute MI, and now it's a huge amount of the left ventricle is affected. That will actually impair the heart's ability for reaching adequate blood flow. If part of the left ventricle is not working, it's just laying there, right? If it is a systolic failure, that means that we will have our problem squeezing, okay? If it is a diastolic failure, then that means we don't get the ability to completely fill, either because of an insufficient valve or something like that, okay? So what causes heart failure? Well, we've kind of talked about it. Acute MI, hypertension, valve disease, and then cardiomyopathy. Now, it could be a regular cardiomyopathy, or it could be an idiopathic. Idiopathic means it has an unknown origin. We don't know why they became having, they started having a cardiomyopathy issue. The pathophysiology of left and right heart failure, you need to be able to differentiate between the two and what kinds of signs and symptoms you will have, and then which treatment goes with whether it's a right or a left, okay? So left heart failure reflects your pump, right? You actually have a decreased pumping ability of the left ventricle. This allows blood to back up from the left ventricle into the pulmonary bed. This then results in a buildup of fluid in the lungs, and they become congested, right? And as it continues to back up, it will eventually back up and lead to a right heart failure. With this kind of failure, we are actually failing to meet the patient's metabolic oxygenation demands in the system, okay? Now, there is your fight or flight sympathetic nervous system's renin-angiotensin-aldosterone system, okay? So when the heart perceives that there's an issue with the pump, right, not being able to get enough information or blood flowing, then it will actually increase your heart rate trying to compensate and get more cardiac output. Now, eventually, that will not do a good job. It will eventually wear out or even become more complicating, because as the heart beats faster, we don't get a long enough fill time, and we don't get a good enough atrial kick, therefore we don't get a good ventricular fill and cardiac output. Now, compare left to right. Right heart failure is where things are backing up from the right ventricle into the right atrium, and then the only other place it has is to the system. So these are the patients that are going to have pedal edema, angular edema, other lower extremity shin edema, maybe even abdominal bloating, because that's all building up with fluid, okay? Now, in heart failure, please know that, remember I said that the ventricle muscle has to stretch and then we get a better rebound? So normal amounts of stretch cause the release of the natriuretic peptide hormone that is actually in the musculature of the ventricle, okay? Normal, that's about 100. But when you have congestive heart failure, that ventricle stretches and stretches and stretches, trying to hold more and more fluid because it's not getting any forward movement, and more blood's coming in, so it's getting overstretched. So anything greater than 100 is indicative of heart failure. I will tell you that I have actually seen BNP pressures, actually BNP lab levels in the 800s and 900s, which is very severe heart failure. So the higher the concentration, the more severe the heart failure. Okay? As the heart failure is treated and there is a recovery, then those concentrations of the peptide will decrease. It is the best marker for you to be able to determine between someone's shortness of breath being a pulmonary issue versus a cardiac issue, okay? So let's go back to heart failure, and again, these are the standards of practice, the nursing interventions, and this is the standards of practice, or in practice world, core measures for heart failure. To improve function, if we're holding things in and getting more and more fluid trapped in there, we can give diuretics and help push the filtration, and the diuresis will help pull excess fluid off, okay? ACE inhibitors are those angiotensin receptor blockers, because remember we say this is the angiotensin-aldosterone system that helps make this worse. Digoxin is a medication that helps improve contractility, or the squeeze, right? Beta blockers such as Coreg help us reduce some of that angiotensin and aldosterone release. And then, of course, we have the BNP medication that's called Natracor, or nesiritide citrate, which this medication is administered IV continuously, and it will help the patient do better diuresing without diuretic therapy, which can cause problems for some patients. And so the natriuretic medication helps to do that diuresis without electrolyte imbalances being of such a great effect. So your overall goal is to reduce cardiac workload. Well, we can actually use some implantable devices, temporary implantable devices, to help us with that. An intra-aortic balloon pump will help us decrease the workload of the heart. A ventricular assist device will help us take that workload off of the ventricle. We can put a pacemaker in both ventricles and help strengthen the activity of the muscular wall. And then, of course, we have a variety of nursing interventions that we need to use to reduce cardiac workload. And that is, we are actually going to do our care on our patient limitedly with frequent and lengthy rest periods. So we will fragment their care in the fact that we will do not a complete bath and a linen change and a shave all at the same time, because the patients can't tolerate that. So we might do a face and hands and let them rest, and then do pits and legs and let them rest, and then do the front of the torso and let them rest. When you get ready to do the back, you need to be prepared to change the linens and do the back fairly quickly so that you can leave the patient and allow them to recuperate. Your biggest job is to optimize gas exchange via your airway, diuretics, and then controlling any sodium and fluid retention issues that can have a contra effect on your diuretics. Another complication of heart failure is pulmonary edema. This is where people are drowning in their own fluids. The symptoms are dyspnea, cyanosis, gurgling, hypoxemia, and a significant sign or symptom is pink frothy sputum. Please don't forget that. That's a classic symptom. And then, of course, another heart failure is complication is cardiogenic shock, and maybe even cardiomyopathy. There's a couple of inflammatory heart diseases that you need to consider when we are talking about urgent issues. Pericarditis is inflammation of the outer pericardial sac of the heart. Endocarditis is an infection of the interior mucoid endocardium, okay, which also includes the valves. The valves are made of that same endocardium lining. So pericarditis, the outside. You must recognize that there are some people who have acute, but there are some people who have chronic pericarditis, and that's very, very painful, and a lot of times they will put them on Indocin to decrease the inflammation and treat that for long-term therapy. Etiology, well, that's the cause. Sometimes an MI causes it. High levels of uric acid causing uremia can cause pericarditis. And even some cancers will help cause pericarditis. Please remember, pericarditis can lead to some kind of pericardial sac infusion causing tamponade and even scarring. Okay? With tamponade and scarring, we reduce the heart's ability to stretch. Now, the hallmarks of pericarditis, of course, the first one is friction rub. And then, of course, pulsus paradoxus, and then initial ST elevations. If there's anything that you don't recall about those, please refresh your memory on them because that's information you will be needing to use. So treatment, well, a pericardiocentesis is where they actually go in and they tap the pericardial sac and they drain it. Now, if the fluid continues to build up, a pericardiocentesis is not helping because they've done a couple of them and we're still getting fluid. The patient will then go into OR and they will actually cut a flap. And we call that a pericardial window, allowing continuous drainage so that we don't get that constricting fluid buildup and get the inflammation. So endocarditis, is the actual endocardium which includes the makeup of the valve, right? So if you have an infection on a valve, then we call that vegetation. It's growing on the valve. Embolization can cause a problem where an embolus goes in and causes death to some of the tissue. And then if I have a valve that is not closing all the way, we call that insufficiency. Or if the valve is closed really tight and hardly opens, that's called valvular stenosis. And both of those can be caused by endocarditis. All right? Cardiomyopathy. This is a condition where the heart muscle is abnormal. Well, we've been talking about many of those. So heart failure, the endocarditis, pericarditis, all of those can lead to cardiomyopathy. There are three kinds. There's the dilated, the hypertrophic, and the restrictive. It means that your heart has a difficult time pumping and delivering the blood to the rest of your body. And then that also can lead to heart failure. So if I started out with heart failure, led to cardiomyopathy, then this becomes a vicious cycle. How do you treat it? Well, the treatment depends on which type of cardiomyopathy you have and how severe or how serious it is. Treatments can include medications, surgically implanted devices such as a VAD, ventricular assist device, and in some severe cases, even a complete heart transplant. Some of the signs and symptoms you need to refresh your memory with. They are breathless with any kind of exertion and sometimes short of breath even at rest. They have perpetual chronic swelling of the legs, ankles, and feet, the bloating of the abdomen. They have a cough when they lie down. They are easily fatigued, constantly fatigued. They have irregular heartbeats that feel rapid or fluttery or even pounding. They will have chest pain. They'll have dizziness, lightheadedness, and fainting, and that's because of the syncopal episodes and the inability to get blood pumping to the rest of the body. No matter what kind of cardiomyopathy, the signs and symptoms are going to get worse unless it is treated. And in certain people, it will worsen very quickly, and then other people, it will take a very long time for it to worsen. It is all an individual situation. One kind is dilated cardiomyopathy. This is the actual most common type of cardiomyopathy, and this is when the heart's main pumping chamber, the left ventricle, becomes less forceful. The contractility has been overstretched, right? So when you overstretch elastic or a rubber band, it gets stretched out and it doesn't get the opportunity to rebound very well. And that's kind of what happens in dilated cardiomyopathy. The left ventricle becomes so enlarged or dilated, it is not able to effectively compress the ventricle and get all of the blood out. Hypertrophic cardiomyopathy is actually the thickening of the heart muscle. I like to compare this one to people who do workouts, like Arnold Schwarzenegger. They have the large muscle buildup from doing weightlifting and that sort of thing. Well, it kind of is the same thing. Your muscle in your left ventricle enlarges, trying to compensate for the decreasing heart rate, and then eventually the muscle itself takes up space that you actually needed for blood volume, and then that causes a decrease in cardiac output. One of the treatments for that would be a wedge surgery, where they actually go in and they cut a pie-shaped wedge out of the left ventricle, and then they sew it back together, allowing the muscle to be reduced and the chamber to be enlarged a little bit. Restrictive cardiomyopathy is where the actual muscle becomes rigid. We don't get the elasticity, we don't get the stretch and the relaxation that we need for filling and for contracting. Now, this can actually occur at any age, but it is most often occurring in older generations. And I like to relate that to the fact that, you know, we get stiffer, our muscles get stiffer, our bones get stiffer, we start losing calcium. So this happens to our cardiac muscle as well. As it becomes stiffer and less elastic, it cannot contract and fill appropriately. Sometimes we have no known cause, and that is an idiopathic cardiomyopathy. Some vascular alterations you need to refresh your memory on are aortic aneurysms, such as dilation, thoracic, abdominal, how to treat it, and what's the difference between a false versus a true. And then these are the different kinds, and this would be a graft repair. So I need you to refresh your memory on that. So here's the difference between an aortic dissection. Please remember this is extremely sudden, sharp, severe pain. They're squirming in the bed and it is unrelenting. The only other pain that is like that is a renal stone or pancreatitis. So you have the opportunity for this to be 3 different things, so you need to always ask more questions and investigate so that you can determine which of the 3 is your situation and you can treat appropriately. So for aortic dissection, surgical repair, they can do an open approach where they actually go in with surgery, or they can do an endovascular approach where they go through the cath lab and go through the femoral artery. Thank you very much. I hope that this has been a beneficial review of cardiac content for complex care patients. Again, this is for Nursing 421, cardiac content review. My name is Professor Land, and I am hoping that this has been beneficial for you. Thank you.